This program is brought to you by Stanford University. Please visit us at stanford.edu.
So it is a great pleasure to introduce Jay Humphrey, and Jay and I have worked together now for a number of years, and we have students and former students that have been a very strong part of this collaboration. Jay has won a number of awards. He's a fellow of the American Institute of Medical and Biological Engineering. We won Young Investigator Awards back in the day, and is a professor of biomedical engineering at Texas A&M, and I'll sit down.
Back in the day, we used to use a slide rule. So first I'd like to thank Charlie and Ron for the invitation to be here, and secondly, and probably more important, is to invite me to being involved in their AAA research. As you'll find out in just a few minutes, most of my research in the past has involved intracranial aneurysms, which I will use as a segue into sort of my bottom line point today. So that said, this is a schematic drawing of the major blood vessels that supply blood to our brains. And what you really want to focus on is that saccular aneurysm in the upper right. And these aneurysms are similar to AAAs in that there is also a loss of elastin. There is also significant smooth muscle apoptosis. There's loss of smooth muscle. They are similar in that they continue to grow, enlarge, many times to rupture. But they are also different in many ways. And one of the ways that they're very different is they tend to not have a thrombus. They tend not to have atherosclerosis. And we heard this morning about rates of rupture or enlargement. These lesions tend to enlarge at a much lower rate, and their rupture rate is actually about 0.1%. So much lower rates of rupture. That's the textbook drawing. This is actually what the lesion looks like. And so we see here that these lesions can actually become quite large. Similar to the AAA, current clinical practice looks at these lesions primarily by maximum diameter. Similar to AAAs, we also know that many of the large lesions will not rupture, where some of the smaller ones will. So there are many similarities despite some of the differences. This is actually data from David Saloner's lab at UCSF, and I think this is the type of information that we're going to need more and more in the AAAs, as well as on the intracranial saccular aneurysm. So this is actually the basilar artery in a patient, and you see this large aneurysm, and what's remarkable is they were able to track over a 5-year period the expansion of this lesion. And what's really not shown here, perhaps, is there was a stenosis in this vertebral artery. So there are two arteries supplying this part of the vasculature. And with this stenosis here, there's essentially increased flow here, and this would be the region of high shear stress. And one might have thought that the region of high shear stress would be where one might expect more enlargement. But in fact, it's the region of low shear stress. And we think that may be related in part to, at low shear stress, the upregulation of adhesion molecules, perhaps capturing monocytes, their invasion of the walls, macrophages, and increasing MMP activity. We heard a lot this morning about MMP activity in AAA, and the same thing is true in intracranial aneurysms. Over the years, there have been many different suggestions as to why these lesions may enlarge and why they may rupture. Without going through the details, many of these hypotheses were based on what I call mechanical concepts, instability. In fact, I once had a surgeon say to me, well, it's similar to a rubber balloon. When you inflate a rubber balloon, you know that you pressurize, and that you get to a point where all of a sudden the balloon enlarges sort of rapidly. This is called in mathematics a limit point instability. Using what I would say more appropriate nonlinear analyses, a number of PhD students in my lab over the years showed that it's unlikely that these lesions enlarge or rupture due to these dynamic instabilities we could call resonance, or these quasi-static instabilities. So the question then is, well, why do they enlarge and rupture, which is the same question we're faced with the AAA. Now, one thing, and I've enjoyed very much this meeting because of the focus on AAA, and we heard a lot this morning about degradation products, MMPs, et cetera. But one thing we haven't heard a lot about is the other side of it, and that is the production. And I think that these aneurysms, like their AAA counterparts, the main question is the balance or imbalance between production and removal. Peter Canham at the University of Western Ontario in Canada has some beautiful results on the histology, the microstructure of these aneurysms, and shows that these aneurysms sort of enlarge or develop, if you will, similar to what an engineer would think would be a good way to stabilize these structures. That is, you have these alternating plies of collagen. And shown here in this picoserous red stained section, this is cut at the dome of the aneurysm. What you see on the outer part of the aneurysm is more white and red. And under polarized light, this gives you an indication of larger fibers, perhaps more mature fibers. Whereas on the inner portion, you see more of the yellows and greens, and so these are the thinner fibers, maybe more reticular type 3 collagen like you would have in a wound healing response. So again, I think we need to think a lot about deposition, organization of collagen as we look at the enlargement and potential rupture of these aneurysms as well as AAAs. So why do they grow? Why do they enlarge and rupture? I think that, as Charlie just talked about very nicely, the hemodynamics clearly plays an important role. And we'll talk about that in a minute. So we think about the hemodynamics telling us something about flow or wall shear stress, something about time-varying pressure. But as we translate that information, which for us in solid mechanics is really information on what are the loads applied to the wall, what we see is here's the wall shear stress, and this pressure will give rise to tensions in the wall. We know that this wall in the intracranial aneurysm has primarily fibroblasts, not smooth muscle cells, has primarily collagen, not elastin or smooth muscle. So here's the schematic, here's the collagen. We know there's a balance between MMP activity, that is degradation of the collagen, and new production. This new production is going to be driven in part through growth factors being upregulated. We know too that these fibroblasts, which are now being subjected to cyclic tensions, that this stimulates them to upregulate various growth factors and produce collagen. We'll talk in a few minutes about what the wall shear stress would do in this role. So one of my, I guess, basic hypotheses is that although there are different manifestations of growth and remodeling in the vasculature, the underlying mechanisms are very similar. So we can learn a lot from other situations. So here, just consider schematically, here's an artery that's being subjected to an increased flow. In response to increased flow, or if you will, increased wall shear stress, the endothelium will increase nitric oxide, which is a vasodilator. And we see sort of a dilatation. Here's a mouse carotid artery, normal and dilated. But we also know that if that is sustained, that increased flow is sustained, then the wall will actually remodel in this new state. And so we get enlargement. And by the way, in our growth and remodeling codes that I'll show in a few minutes, we actually predict with this enlargement due to increased flow a lengthening, which is similar to the cyclist example you showed. On the right-hand side, we see what's the case of increased pressure. Now, these are cerebral arteries. We're focusing here on the media and the collagen in the media. And so with increased pressure, one knows that the wall tends to thicken to restore stress back to normal. And again, that is invariant. The pressure is invariant and the tension is invariant across the multiple species, which was shown by Glagoff back in the mid-70s and early 80s. So we see here that if we increase pressure, we get a thickening response. If we increase flow, we get this enlargement. And we know pretty well what the underlying mechanobiological factors are. So can we, when we go back and look at this aneurysm and we see altered flow and altered pressures, can we use those same ideas to try to understand how these lesions enlarge and eventually rupture? So here's our hypothesis, and I will actually modify this by the end of the talk, but essentially mechanically induced growth and remodeling seeks to maintain constant some preferred or what we call homeostatic state. It may be wall shear stress at a target value, it may be intramural stress. It does this in large part, this is achieved through the replacement of previously existing constituents. So that is the degradation, but it's also the synthesis, and it's that balance which is really key. So we've tried to develop a general theory, and here's my one, I think, equation slide. Rob mentioned earlier, this is F equals ma, so we do respect Newton. This is the continuum description of that F equals ma. This is my expression for stress, and all this does is remind me to tell you that the stress will depend on F, and F is just how much is this tissue deforming. Okay, so as you stretch the material out, it increases in stress. And this W reminds me to tell you that just like a rubber band, if you stretch the rubber band out, you store energy in it. And when you let go, that energy is minimized, and that's what will restore the rubber band. What we'll do is actually consider the energy stored in different constituents in the wall. elastin, which would be different than collagen, which would be different than smooth muscle, etc. On the top, in addition to conserving linear momentum or Newton's F equals ma, we also have to have a mass balance equation. And these two equations remind me to tell you that I is essentially an index that tells me I have different soluble factors that may be important, various MMPs, say nitric oxide, endothelin, different vasoactive molecule, different proteases, etc. And so this equation essentially gives rise to the standard reaction diffusion equation that chemies are very familiar with. And we'll talk about that in a few minutes. This equation is mass balance for the non-soluble, that is insoluble constituents like collagen and elastin. And this turns into this equation. And this is really the key equation for our new theory, and let me walk you through it. We know that all cells have a finite lifespan, if you will, and all proteins have a finite lifespan. And so this Q is a function that tells us essentially the rate at which these proteins will degrade. It essentially accounts for their half-life. We know that vascular collagen under normal conditions has a half-life of about 70 days. In hypertension, that half-life will reduce to 7 days. So it can be rapid turnover in hypertension. We also know that under normal conditions, vascular elastin has a half-life on the order of decades. So this Q will account for how rapidly the original material will actually degrade. And that will increase in cases of disease. Well, we also have, in addition to degradation, we have to have production. So M is essentially a term that tells us the rate at which the cells are synthesizing new material, all of which will then degrade under its separate sort of degradation kinetics. So what we do in this equation is essentially say the energy that we store in this artery, this aneurysm, will depend on what constituents are there and how they're being stretched. It also depends on essentially how fast that material is being degraded, so we can lose elastin and essentially weaken the wall. And we can replace that with new collagen. So this allows us to take the mechanics from what we've always done in the past, which is, given this stretch, what is the stress? Now what we're going to say is, given this stretch, how does that affect the cell biology, the turnover of the material, which will then affect the evolving, if you will, properties of the wall? So here's an example of how we've used this. This is a basilar artery from a rabbit. The arrows just show they show microspheres that we use to essentially occlude the perforator so we can do pressure diameter test. On the right you see pressure diameter data, the blue circles, at different axial stretches which are appropriate for a cerebral artery. In the bottom you see the axial force. How much force does it take to maintain that vessel at a certain length as you pressurize it? We also use multiphoton microscopy to essentially survey this collagen orientation through the wall, as well as elastin. And that information then goes back into this model, whoops, wrong one, goes back into this model so that we can not only say how much energy do we store in a particular constituent as the vessel is deforming, but it depends on what the orientation of that constituent is, and we take that into account. So the red line simply showed that that equation can fit data at time 0 reasonably well. So here's really the main slide. What we show here is an academic growth of an aneurysm, so we're going to keep it simple, that is axisymmetric. What we've done is we've endowed this wall with various properties, that is elastin, various families of collagen with the orientations that are measured, and smooth muscle. Then at time 0, we essentially numerically degrade a small amount of the elastin, thought to be in intracranial aneurysms like AAA one of the initiating events. That degradation will, of course, weaken the wall locally, which will cause the artery to bulge out slightly under the same pressure. Because of this slight bulge, we have actually changed dramatically the stress in this region. And we think that the stress seen by the cells will actually affect the rate at which the cells will produce or remove matrix. And so now our goal is to essentially evolve this aneurysm numerically with different hypotheses and then compare these competing hypotheses. So if this video will work, again, this is an academic exercise where we're looking at an idealized case where we initially remove elastin from the wall and have an associated loss of smooth muscle. We know that elastin sends an important biological cue to smooth muscle to be anti-apoptotic. So all we've done is removed a small amount of elastin and smooth muscle, and then we ask, what would the vessel do if it were to try to maintain constant the tensions in the wall, which, as Charlie mentioned earlier, tends to be in very across species and also vessels? And the answer is it will start to grow. It will start to enlarge, and similar to, again, a textbook type of problem. This shows at a few times during that growth, and what I really want to point out here is something that when I talk to the neuroradiologist, it's maybe a little bit hard to believe. So this is just the profile of this artery soon after we removed a small amount of the elastin. And what you can see is just barely a small bulge. In fact, the resolution of the plotting shows this sort of stepwise. That's just a small bulge. Well, it turns out if you go through the mechanics and solve the problem, even though you have a small change in geometry, the stresses, which were normally this in the native vessel, peak to something like this. So this small change in geometry can actually give rise to a large change in stress, which we think the cells then sense and say, we would like to reduce that stress. So as we allow this vessel to numerically grow, which is by removing the old overly stressed constituents and replacing them with new constituents, this vessel enlarges, and what you see is even in this first time step, this large change in geometry, the stresses come down dramatically. And if I showed you here, you can see it's a curve converging to this geometry. The stress will essentially go back to normal. So we think that this is consistent with a lot of the data that we've seen in flow-induced remodeling, hypertension, et cetera, and indeed is explaining some things we see in aneurysms. Now you might remember a term I mentioned before, M. This was the rate at which the cells are producing new material. For example, collagen. This collagen is being produced continually in the vasculature. But in cases of disease, or in this case, the aneurysm developing, if you change the stress from its homeostatic target, we think that the rate at which that collagen is produced actually increases. So we show here numerically that if this aneurysm just continues to turn over material at its basal rate, it's unstable. It would grow without bound. But as soon as you allow the vessel to increase the rate at which it produces collagen, you can actually get stable lesions. And again, the cerebral circulation, the vast majority are stable. The rate at which they rupture is less than 0.1% per year. So we think that that is encouraging. The other thing that's important, though, is the direction that the tissue lays down that collagen. In this case, regardless of whether there's a stress-mediated turnover or not, in these three simulations, we essentially see unbounded growth. And what we did is we told, if you will, the numerical cells to put down collagen in the direction of the maximum stress. But in fact, if we told them to put down the collagen in the direction of the maximum strain, or if you will, dilatation, then you get this result where you get stabilization. So it depends on the rate at which you put down the material, the orientation you put it down, its cross-linking, etc. Now, I mentioned that one thing that's different between the intracranial aneurysms typically and the AAA is the lack of a thrombus. So we have studied the effect of thrombus, but extraluminal, not intraluminal. So here's our same aneurysm as we saw before. If this aneurysm ruptures and the blood gets into the CSF, it will get around otherwise normal vessels. The adventitia is collagenous, which is thrombogenic, so you form a clot, and it leads to the clinical condition called cerebral vasospasm, which is actually the leading cause of death in these patients. So let's look at this clot, or the effects of this clot. Here's a result from a paper in '92. Here's a normal artery. Here's an artery that's been subjected to extraluminal blood that is a blood clot, and what you see is over a short period, that is about 7 days, about a 50 or 60% change in that diameter. And the thing to point out here is that this is, if you will, irreversible. You give a vasodilator and you don't go back to here. There's actually active remodeling that restores, in a sense, or that maintains this vessel in this constricted state. If you look at the normal histology, the main thing to point out here is at day 21 versus control. The pink is largely smooth muscle. You see a normal media. Here what we see is a lot of blue, and in this particular stain, that's showing new collagen that's been produced. So as this vessel constricts down, there's new collagen production, again at a much heightened rate because of this chemostimulus. Here immunohistochemistry shows a transition from a more contractile smooth muscle phenotype to more synthetic, the brown staining consistent with the collagen deposition, and then here the converse, with the return back to the contractile phenotype after 3 weeks. Just as in the AAA, this thrombus is releasing a multitude of factors, many of which we heard discussed this morning. I will point out serotonin, thrombin, thromboxane, et cetera, many vasoconstrictors which cause the initial constriction, and then we see a lot of MMP activity and actually growth factors that would stimulate a remodeling in this constricted state. One of the big differences, I think, between the intracranial and the AAA is that this clot will resolve or dissolve within about a period of a week. It's not continually replenished by the intraluminal blood. Shown here is that basal production rate. It's being changed now because of changes in stress, but now changes in constrictors. And I'll talk about that in a minute, but let me just show you what we think is going on. The constrictors seen by the smooth muscle cells include the basal value. This is the balance between NO and ET, ET1. This is modulated through changes in wall shear stress. As wall shear stress goes up, NO goes up, nitric oxide. As wall shear stress goes down, endothelin 1 goes down. So that would change this constrictor. What we're modeling here is the clot. So here's the clot burden. There are different reports in the literature, but this red curve is probably the most reliable, essentially showing that time 0, here's the bleed. You get a tremendous clot burden, dissolve the clot within 5 to 10 days. So what we do in the model is essentially now let the turnover rate of the collagen change not just with stress, but also with this ratio of constrictor, because we know constrictors like endothelin 1 promote collagen synthesis. Dilators like NO actually delay it. And what the model then shows is essentially here's that inner radius decreasing at about 7 days and then going back to day 21 after the clot is dissolved. Interesting here, because we've reduced the lumen, we've thickened the wall, the stress actually goes down. So even though the stress has gone down, the collagen production has gone up, again because the chemical insult is dominating over the mechanical. So we call this sort of a biochemomechanical theory. And so here what we see is the normal pressure diameter behavior of that vessel, and at 7 days it's stiffened tremendously. And this is the clinical problem. You give a vasodilator, you have a constricted vessel that's very stiff, and you cannot get it to dilate. But as the collagen turns over after the removal of this constrictor burden, you actually do go back within about 4 weeks. So I said earlier that one of the driving hypotheses in my lab is that even though there are different manifestations of growth and remodeling, the underlying mechanisms are very similar. So we've studied hypertension in various animal models. We've looked at altered flow. We have looked at Marfan syndrome with a fibrillin-1 deficient animal, and we've looked at intracranial aneurysms and vasospasm, beginning to look at aging. I think that these same ideas will be applicable to the AAA, and I'm excited to work with Charlie, Ron, and Professor Holzoff will mention this morning, and David Vorp at Pittsburgh on this new project. So these are results that are very new. Professor Beck at Michigan State on, here's a sample of infrarenal aorta. Again, simply removing the elastin, smooth muscle activity, and showing that these same ideas would start to evolve, if you will, something that's going to begin to look like an aneurysm. So my parting words, sort of closing thoughts as Charlie had, I think over the past 3-4 decades, we in biomechanics have really been driven by this question, what is the stress and what is the strain and can we predict failure, et cetera, and this is very important. But I think now what we need to do is embrace more what we know about the biology or mechanobiology, and then say, well, once we know what the stress and strain are, then how does that affect the evolution of geometry, properties, and function? And this is going to require models such as growth and remodeling models, which we have started to develop. But I think where we need to go now is actually look at this stimulus and what it's doing as far as affecting the production of various effector molecules, the growth factors, the MMPs, et cetera. And so instead of having mass density productions depend just on differences in stress from target values, also looking at changes in constrictors. And there are 2 quick examples. So we know from correlation that eNOS and hence nitric oxide increases with increasing wall shear stress. You can see there's a paucity of data that we've pulled from the literature. We need more information like this, so we have what I'd call a mechanical dose response curve. Here's the production of this molecule of interest. Here's, if you will, the concentration, in this case stress. We need better information, but that still gives us a lot. We also said earlier that as you increase NO, here's a NO donor, that collagen synthesis goes down. So we can begin to build into our model. We get information on wall shear stress, as for example from Charlie's fluid-solid interaction code. That will tell us something through correlations like this, how much NO might be produced. Through reaction diffusion equations, then we can talk about what's happening at the level of the smooth muscle cell with regard to inhibition of collagen synthesis, as shown here, or changes in smooth muscle activity. And in fact, there's now a growing literature where we understand better the actual mechanisms of the production of NO, its diffusion, and its action within the smooth muscle. With regard to cyclic stretch, or if you will, wall stress rather than wall shear stress, we also know as you change the cyclic stretch on the smooth muscle cells, that will change their production of collagen. Again, a very similar, although you see again a paucity of data. It's becoming clear that the way the smooth muscle is producing this collagen in response to mechanical stimulus is through these various chemical effectors. Probably changes in conformation. We heard this morning about the AT1 receptor. Stress will change conformation, hence binding. This will lead to, along one particular signaling pathway, the production of TGF-beta, at least in its latent form. We now know that TGF-beta can be stimulated or activated, if you will, through mechanical stimulus, and then through its SMAD signaling pathway lead to this collagen production. We also have some feel as to whether the degree to which that collagen production changes with things like Ang2 concentration, with peaks measured at 10 to the minus 8 molar. So what I'd like to do, and what one of the things that we're doing in my lab, is to try to synthesize this, what I'd call mechanobiology. How does this mechanical stimulus result in a biological activity? Couple that to the mechanics, wall mechanics, which then can be coupled to the fluid mechanics. So this is the schematic that Charlie and I have used, Alberto actually generated for us. Using Charlie's fluid-solid interaction codes, this will define the stresses, if you will, seen by these cells. Then our growth and remodeling code will take that and the mechanobiological information and try to grow, or essentially evolve the geometry and properties, which gets fed back in a loosely coupled manner so that we can try to understand not just whether or not at a given time a lesion is susceptible to rupture, but indeed how it might evolve from that point. So with that, I will end. Again, I thank you, Ron, Charlie, for the invitation. And again, the invitation really beyond just being here, but to be involved in trying to understand AAAs. Obviously, like others, a lot of different people have contributed to this, and I'll stop there. Thank you.
So why don't we take some questions? We have some time.
Yeah. It's a really nice presentation and a good opportunity to try to link what you're doing as an engineer with what the vascular biologists are trying to do to understand the biology. The thing that troubles me is trying to create an equation to account for something that's changing in time and that interacts with other biological factors. And we know in vascular biology that things are happening very quickly and they go backwards quickly and they interact. And so how do you account for that in these complex equations?
Well, I think the answer is that we're just beginning. I'm glad to hear that you would agree that we need to bridge the mechanics and the biology. We're just beginning. But I think the same challenge exists in systems biology. If you think about all of the reaction equations that we're coming up with in systems biology to understand within a cell, literally hundreds perhaps of simultaneous reaction equations which are time dependent, we're facing the same challenges here. How will we meet them? I think the answer is the more reliable the data, then the better we can describe this through these evolution equations. I don't think this is going to be an overnight solution or success. I think there's a lot of hard work, and what I think we need to do is set the direction. We need to get people in agreement that if an engineer says, well, this is something I need to know, this mechanical dose response curve, then the vascular biologist would say, maybe that makes sense, and the vascular biologist will come to the engineer and say what you just said. These things are changing both in forward and sort of backwards pathways. How do we account for that? Well, we can work on the reaction kinetics that may be appropriate. Maybe I'm optimistic, but I'm confident that we'll be able to at least go to the next level, which I think is going to be correlative, And then the challenge is going to be to take it to the next level, which would be more mechanistic. But from a clinical perspective, I think even the correlative would be a help. But your point is very well taken. Yes.
Sorry. Do you want to do comments first?
Professor Humphrey, great presentation. Curious to know how the notion of homeostatic stress is arrived. How do we get those values? Do they get affected by the change in composition? Any thoughts or insight would be appreciated.
Well, again, I think it goes back to Glagoff's early observation, essentially that across species and during development within a given animal, that we see that the aorta, for example, will continue to put down more layers as the pressure increases during development. It will put down more layers as it needs to with increased blood flow and hence dilatation. So as you change the stress, the wall's adapting to it.
But in terms of getting some values for that, any thoughts on how do we arrive at?
It's very easy to get the mean value because that's statics alone. It's pressure times radius over wall thickness, as Glagoff said many years ago. I think that homeostatic target is pretty reliable, just as I think what Charlie was talking about, the wall shear stress, albeit different in different species, we have a pretty good idea of what that is. So defining normalcy is not so bad. Trying to figure out how well the cells are able to maintain that is a different issue. And obviously it's done in different ways under different circumstances. The prime example would be in development, as the aorta thickens, it thickens by adding additional layers. And it restores the stress or keeps the stress at normal values. In hypertension and maturity, you thicken within a layer, you don't add additional layers. So there's sort of this physiologic constraint, and it's probably because we're not making elastin, which is part of that layering process.
Bring the microphone up front, too.
They say there's no dumb question, but this might be one. But did I understand that you were saying in that little movie that the enlargement into an aneurysm was to reduce the wall tension as a coping strategy? Because every textbook invokes the law of Laplace to say that the opposite. I mean, that it increases the wall tension. Is that just?
Well, there are a lot of things in textbooks that are wrong.
Yeah.
That's one of them. Our feeling is that, I mean, the simple way I explain it to sophomores is, is if you can't be a tube, you'd like to be a sphere if you're a pressure vessel. And so if you think of Laplace for a sphere and for a pressure vessel, as the radius gets larger, you get this factor of 2. So being a sphere is not a bad thing, but you'd rather be a tube in this case. And what two things can restore it to be a tube? Well, one thing would be the elastic recoil. So you get this dilatation. So the elastin is highly pre-stretched. It could recoil back, but that's being degraded. So you've lost the ability to recoil. The second thing that can bring you back is what? Smooth muscle contraction. But you're losing smooth muscle. So even though you would like to, in response to this local dilatation, actually restore the tube, you can't. So the next best thing is to start to actually grow more spherical. And I think that if the pressure was uniform, then what you would see is a spherical lesion. And in fact, many of the cerebral aneurysms do that. The complicating factor, which gets back maybe to this issue, is you're not only trying to maintain wall tension, but you're also trying to maintain the hemodynamic stress, wall shear stress. And so now what's happening is you're evolving something that's helpful with regard to wall tension, you're disturbing the flow. So now there's this complicating factor. Now it's a question of what do you balance and how do you do it, which is why we're really anxious to couple. That simulation was based on uniform pressure, no shear stress. We've just recently submitted the first paper where we've coupled the two, and as soon as you include shear stress, it breaks the symmetry. And you start getting more complicated shapes, as in the aneurysm. So the simple answer is if it's just pressure, yes, it makes sense you want to become spherical. What perturbs it from that is probably disturbed flow. And the endothelial cells locally producing NO or ET or at low shear, upregulating adhesion molecules and capturing monocytes and getting protease activity. And I think that's sort of the vessel can't win, in a sense, and it gets on this slippery slope.
Maybe Cody. Right here.
Quick question. Great summary, by the way. And for those of us tasked with product development, the question that comes to mind for me, if you're trying to exclude an aneurysm and you're putting a device in, a self-expanding device or a balloon expandable device, one where you have a chronic outward force and one where you have an acute, that, what's your thoughts on the remodeling mechanism that goes on there?
I guess I have two thoughts. One is, and we had this discussion at the FDA in the spring, I think that we need to start accounting for the anticipated remodeling as we design these devices. We need to understand better what are the loads imposed by the device on the wall, because I think we have a fairly good idea of how the cells respond to changes in load, at least in culture and in some simple experimental conditions. But I can't answer the question specifically because I don't know what the loads are. But I think Chris and I have talked about with these endografts and some regression of the aneurysm, and that would make sense. If you offload it and you take that stress away, now you're remodeling in configurations that are becoming less stressed, and so that makes sense. It's like ventricular recovery and LVAD treatments. That if you can offload the structure and it can recover somewhat where it was, then you remodel in that state. But as far as the specifics, I mean, we'd have to talk about the detailed tractions between the two surfaces.
The preceding program is copyrighted by Stanford University. Please visit us at stanford.edu.